Welcome, dear colleagues, to this ERS webinar. My name is Marc Miravitlles. I am a consultant in the Vall d'Hebron Hospital in Barcelona, Spain. I am dedicated basically to research in COPD and alpha-1 antitrypsin deficiency. And I had the honor to be co-chairing the ERS guideline on withdrawal of inhaled corticosteroids in COPD together with my colleague and friend, Professor James Chalmers. I know that you probably know very well Professor Chalmers. He is consultant respiratory physician at the University of Dundee in Scotland, and also he's the chair of respiratory research of the British Lung Foundation. And I am sure that you also know him for his role as deputy chief editor of the ERJ. We are going to talk and discuss today about the role of inhaled steroids in COPD, and in particular to identify patients that can be safely discontinued from ICS. And during the next 40 minutes, James will be presenting the background information, the development of the guideline, and also he will illustrate the application of this guideline in different case studies. But this is going to be a very interactive session. So we want to know your opinion, and we also want to know what would you do in the different case scenarios that we are going to present you. So be ready, because we will ask you also to give us your opinions. And don't forget that you can post questions through the chat, and we will do our best to address all your questions at the end of this webinar. And for the interest of time, I have nothing else important to say at this point, so I just want to pass the word to James. James, the floor is yours.
Thank you very much, Marc. I would also say it was a great pleasure to share this guideline with you. And I'm going to really enjoy sharing the learnings from that guideline over the next 20 to 30 minutes during this interactive presentation. As Marc said, we're going to have a number of questions as we go through, and it really would be great to hear your opinions through the chat, because I think one of the difficulties when you're writing a guideline is thinking about how that's going to be implemented in lots of different people's clinical practice. And so it would be great to hear about the challenges and the thoughts that you have about inhaled corticosteroid withdrawal as we go through this presentation. So if we can now just bring up the slides, there we go. So before we get started, these are a few of my disclosures. I do a number of clinical trials with pharmaceutical companies in the field of COPD, bronchiectasis, and other respiratory infections. So it's important you're aware of that before we get into the discussion of the data. So what we're going to cover during the formal presentation part of this webinar is the indications currently for inhaled corticosteroid in COPD. We're going to talk a little bit about why we're withdrawing inhaled corticosteroids, which is about, to some extent, the risk of side effects or other risks associated with inhaled steroid. We'll talk about the criteria for inhaled steroid discontinuation, which is the guideline that we developed with Marc through the ERS, and then some aspects of the practicalities of withdrawing ICS in COPD. So before we start, we're going to warm up our voting ability by voting on what do you think is the main indication in your practice for using inhaled corticosteroids. So the options are to reduce exacerbations, to improve lung function, to reduce breathlessness, to prevent long-term lung function decline, or to reduce mortality. So you should be able to vote by clicking on the buttons. I've just learned that panelists can't vote, so me and Marc are not allowed to have an opinion here. And the results should come up in a second. Okay, still waiting for the results. There we go. And 81% say to reduce exacerbations. So I think the message has gotten out there very well, Marc.
That's right. That's right. So this is a good start for our webinar today.
Yeah. So the primary indication for inhaled corticosteroids are to reduce exacerbations. There's been multiple trials over the years looking at the impact of inhaled steroids on many of these other endpoints. But the principal benefit of inhaled steroid has been in specific populations to reduce exacerbations. And that's recognized in the GOLD guidelines and in the GOLD assessment criteria for deciding both initial therapy and ongoing therapy. I'm sure all of you are familiar with this algorithm that we classify patients now not based on lung function, but based on symptoms and exacerbations into the A, B, C, D classification system, with those with frequent exacerbations or a hospitalization for COPD being classified into the C and D categories. And these are the categories where we predominantly think of inhaled corticosteroid because of the information we've just discussed, which is that most of the trials show the primary benefit of inhaled steroid is to reduce exacerbations. So one of the innovations in the new GOLD strategy in 2020 was to separate initial therapy on the left-hand side of this slide from follow-on pharmacological therapy on the right-hand side. And you can see that inhaled corticosteroids do not feature in the initial therapy for GOLD A, B, or C, and are part of the options given for Group D, where Group ICS LABA is the only option for initial therapy, and only in patients that have a significantly raised blood eosinophil count. And when we look at the pharmacotherapy for follow-up, so this is in patients that have already received initial therapy, usually with a bronchodilator. For those with dyspnea, again, the focus is primarily on bronchodilation for pharmacotherapy. And even the suggestion here is that if patients are receiving ICS, you may wish to de-escalate ICS to bronchodilator therapy. And for those with exacerbations, after trialing LABA/LAMA or bronchodilator therapy in those that have a raised blood eosinophil count, and we're going to talk quite a lot about eosinophils later in the presentation. Those that have a blood eosinophil count above 100, there's a suggestion to try ICS, but not in those with the lower blood eosinophil counts. And so the natural extension of this, would be that the vast majority of patients, if we followed the guidelines, would be receiving bronchodilation, because the vast majority of patients with COPD have dyspnea as their predominant problem, whereas very frequent exacerbations probably accounts for 25% or so of COPD patients, particularly when you pull in the requirement to have raised blood eosinophil counts. So if we think about that and the statement that I've just made that around 25% of patients based on those indications in the guidelines should be on ICS. If you think about your own practice and the patients you see, what percentage of patients in GOLD A and B would you find are prescribed inhaled corticosteroid? And I'll be interested in the outcome of this one. Again, we just have to wait a few minutes. That's fantastic that I already see questions coming through in the chat. Please keep sending those through, because we have a whole section towards the end of the webinar dedicated to the questions, and Mark and I will try and get through as many of those as we can. There we go. So much more split this time, Mark. So in your practice in Spain, what proportion of these patients do you think you would see taking ICS?
Well, A and B, I would say between 25 and 50% as well. Yeah, this is my experience. Although I don't know in primary care if this could be the similar percentage. I'm sure you will go through this in your next slides. Yeah,
so I think in my practice, I would say I see roughly the same as the majority here, which is 25 to 50%. Some of the data suggests it's even higher than that, as you'll see in a moment. So we did a study a couple of years ago looking at ICS prescribing in the UK. So this is using a registry called the UK Clinical Research Practice Data Link. So it has primary care data and looked at GOLD A and B patients. And it's registered between 2005 and 2015. And what you can see is that going back all the way to 2005, nearly 80% of patients, their first prescription was for an inhaled corticosteroid. Now that's gold A and B patients, so patients that shouldn't necessarily be receiving an ICS, and excluding asthma. But what you can see is that there's been a substantial improvement over time, probably starting around 2007 when the TORCH study came out and the first recognition of pneumonia as a complication of ICS. And since then, there has been a gradual reduction in ICS prescribing as the initial therapy. And it's now in that range of 25 to 50% that the majority felt was also what they see in their practice. But there is evidence of ICS overprescribing. I've just shown you the data for initial therapy, but at all stages of therapy, we see rapid escalation to triple therapy. This is from a study that was published by Guy Broussel and colleagues, where they looked at patients that had ended up on triple therapy and looked at how quickly they had got their time from diagnosis in relation to the severity of their COPD. And if we were prescribing according to guidelines, you would expect that gold D patients would get to triple therapy much more rapidly. And you can see here the lines are basically superimposable, meaning that patients who have much milder COPD are getting to inhaled steroid and triple therapy just as quickly as patients in gold D. That suggests overprescribing of inhaled steroid, particularly in early COPD. And we obviously all recognize that in our practice. And that's the background to the guideline that Mark and I published at the end of last year in the European Respiratory Journal. This is a guideline, the first guideline I'm aware of, specifically addressing the issue of withdrawal of inhaled steroid. And the motivation for doing a guideline on this topic is that clinicians tell us that this is something that they find difficult. They would like to do this for some of their patients, but there wasn't formal guidance on this topic in a detailed way in other, particularly national guidelines. But clinicians tell us they would like to do this. They see that this is an issue, and they see overprescribing as an issue. What's your primary motivation? You've come to an ERS webinar on stopping steroids, so you must be motivated to think about this topic. What's the main motivation for you? Is it less burden for the patients taking unnecessary treatment, reducing costs, reducing steroid-associated side effects? Or do you think some patients will do better in terms of exacerbations and symptom control if they're not taking inhaled steroid? And we'll wait another second for this to come back, and then I'll put it to Mark to ask his motivation for doing this in the majority of patients. And that's interesting. So 65% say that the primary motivation is around the adverse effects of steroids. So what do you think about that, Mark?
That's right. So I would have responded the same. I don't expect better outcomes in terms of exacerbations after withdrawal, although we will also discuss the possibility that in some patients there may be an increased risk of infections, including infectious exacerbations. But in the majority of cases, I would agree that my main objective is to reduce associated side effects. Would you?
Yeah, so I would certainly say that one of my major motivations is that, but I also would go with the 23% who talked about just avoiding unnecessary treatment. I'm a great believer that good medicine is using drugs only when they're indicated. And so even in a patient that I thought was low risk for steroid-associated side effects, I wouldn't want to give them a treatment that wasn't going to benefit them. And so I think probably all of these 4 points, or at least the top 3 points, feed into our motivation to want to withdraw steroid when it's appropriate to do so. But the side effect issue is definitely the one that we hear most frequently, and so you can tell from the fact it's the next slide. I predicted that would be the primary motivation for most people. The most famous, I think, is the association between ICS and pneumonia. This has been shown in virtually every inhaled steroid trial since 2007 and the TORCH trial. I've shown here the risks that were seen in IMPACT, which was one of the largest ever studies of inhaled steroid and in triple therapy. And you can see the clear difference between the two ICS containing arms in green and blue and dual bronchodilator in orange. Now, the orange is not zero because people with COPD are at higher risk of pneumonia because they have an underlying lung condition, but you can see the marked increase in patients taking ICS that's been replicated in virtually every study that's looked for this. But it's not just pneumonia, although pneumonia clearly happens and happens frequently in people with COPD. There's emerging data that patients with ICS treatment are at increased risk of mycobacterial disease. There are associations with osteoporosis and bone disease. This is from a study by a paper by David Price. Although it's stated here there's no effect on fracture risk, there are some studies that show that, certainly observational studies. Some patients do complain of skin bruising and skin thinning. Cataracts, diabetes, oropharyngeal candidiasis, I think, is a significant problem that many people experience when they're on high-dose inhaled steroid. All of these feed into reasons why we would want to use these drugs in the appropriate patients. Why does pneumonia happen? I think this is absolutely fascinating science. So this is a study from London, from Science Translational Medicine last year, where in both humans and mice administered fluticasone, they showed an increase in the red here, which is the relative abundance of streptococcus in patients receiving inhaled steroid, and then in mice administered fluticasone, showing that it alters the bacteria in the lungs, predisposing patients to an increased risk for developing respiratory infection. So taking an inhaled steroid will affect the inflammatory environment in the lung, but it also seems to change the bacteria in the lung, which may make us more susceptible to infection. So the key question is not should we avoid steroids, because we know they have a role in COPD. It's picking which patient should receive inhaled corticosteroids. And so here it's about inflammation, and I can see comments already coming through about inflammation in the chat. This is really about inflammation. And our old simplistic view of inflammation in airways disease was that COPD was a disease caused by cigarette smoke, that alveolar damage and inflammation caused recruitment of neutrophils, and that was a non-steroid responsive process, so there's no role for steroid. Whereas asthma was a primarily allergen-driven process, leading to the recruitment of eosinophils, which are exquisitely responsive to steroid, and that's why that's a steroid-responsive disease. We now know that that's completely wrong, and in fact, there are inflammatory phenotypes or different inflammatory subgroups within both COPD, asthma, and other airways diseases. You can find eosinophilic COPD, you can find neutrophilic severe asthma, and it's important, therefore, to think not about necessarily the underlying condition, although that plays into things, but actually about the inflammatory phenotype of your patient. The concept of treatable traits that you may have heard of is all about thinking about treating your individual patient based on their individual characteristics, rather than imagining that everyone fits these textbook definitions. And eosinophilia is something that we can directly target because of the fact that blood eosinophil counts, which are available in routine clinical practice, correlate to some extent with sputum eosinophil counts, which we can't easily measure in clinical practice. So we can look at a patient's blood counts and say, this looks like a patient that has eosinophilic inflammation because they have raised eosinophil blood counts. And I think this is the best visual representation of this relationship, and it's from Mona Bafadel's study in the Lancet Respiratory Medicine. This is from a series of trials conducted by AstraZeneca of inhaled steroid versus bronchodilator. And what you see from this data is on the x-axis is the blood eosinophil count for groups of patients. And when patients are prescribed a bronchodilator, in this case formoterol, an increasing blood eosinophil count is associated with an increasing risk of exacerbation. But when the patient is also receiving an inhaled corticosteroid, that eosinophil-dependent increase in exacerbations is blunted. So it's not that patients aren't having exacerbations, but a proportion of those exacerbations that appear to be driven by eosinophils are being prevented. And so your responder population, which is what's shown in the bottom, are those with raised eosinophils. The higher the eosinophil count, the more likely the patient was in this and other analyses to respond to an inhaled steroid. And so we have a meta-analysis. We have many meta-analyses on this topic, but this one that was published in the ERJ, I think, is useful because it gives us some quantification to the degree of benefit we see to using eosinophil counts in practice. Now, what I just showed you is a linear relationship between eosinophil counts and response to steroid. So 200 is better than 100, 300 is better than 200, 500 is better than 300, which makes it difficult to pick cutoffs. But we as clinicians naturally find cutoffs useful because we have to make decisions in practice. Linear variables are quite difficult for us to work with. And so many have identified 300 as a useful clinical cutoff because it seems to be the point at which benefit is really consistently shown in studies. So in this analysis, which was a meta-analysis published in the ERJ, the authors have looked at the benefit of triple therapy with ICS, LABA, and LAMA versus bronchodilator therapy in those two groups of patients, depending on their blood eosinophil counts. And the number needed to treat, which is an estimate of the efficacy of the drugs, is really strikingly different between the two. The number needed to treat here is 9 to prevent 1 exacerbation in the high eosinophil count population. That's still not some sort of magical treatment. If I said to a patient, this is going to prevent 1 exacerbation for you every 9 years, they're not going to shake my hand and say that's a fantastic treatment. Thank you, doctor. But if I said this is going to prevent 1 exacerbation every 46 years, I think they would say, have you not got something better you can offer me? And so I think this does help to quantify at least that there's a big difference in the benefit in patients that have eosinophil counts that are elevated versus those that don't. Accepting that these are estimates from pooled analyses, and there's quite a degree of variability between the results and the patient populations in all of these studies. So a nice way of summarizing all of this is that in terms of inhaled steroid response, there seems to be very little response below about 100 cells, and you saw that in the Bafadel graph very nicely. Above 300, there is clear evidence that patients do better when they're prescribed inhaled steroid. There's an important point to make here, which is all of these trials include patients that have a history of exacerbations, and we'll come back to that, which is a very important issue. And then there's a group between 100 and 300 where there is a degree of benefit. And it comes down to that clinical decision of whether the degree of benefit is sufficient to justify the decision to prescribe. And we make those kinds of decisions all the time as clinicians. So Mark and I, with a panel of experts, had to synthesize all of this data, now thinking about when should we be trying to withdraw inhaled corticosteroid. So we've talked about the indications. We've talked about that data on eosinophils. So we set our Pico question, which is the question we have to address in a guideline, as patients with COPD currently treated with inhaled steroid. Should we withdraw or should we carry on with inhaled corticosteroid? And the important questions to address within this were, should we withdraw it in patients that don't have a history of exacerbations? What should we do in patients that have or don't have evidence of blood eosinophil counts? And we pre-specified that based on the literature that I've just shown you. So we did a literature review with input from a panel and a methodology group. We rated the evidence in terms of its quality, and we extracted all of the data on inhaled corticosteroid withdrawal and performed our own meta-analysis, looking at trials that specifically withdrew inhaled steroid. And based on all of that, we used a standardized methodology called GRADE to make recommendations. And we identified 4 studies that had specifically done randomized controlled trials of inhaled steroid withdrawal and followed patients up for long enough to look at important outcomes like exacerbations. So there were 4 trials. In the interest of time, we're going to focus on 2 trials that were the largest and most informative for the guideline. And these are the WISDOM study, which is a randomized clinical trial where after a 6-week run-in, patients taking triple therapy were then randomized to step down slowly to dual therapy with bronchodilators or to continue with triple therapy. And the ICS was withdrawn slowly over a period of 3 months. And the second trial is called SUNSET, and this was a 6-month rather than a 1-year trial where patients were taken off their inhaled corticosteroids abruptly. So there was no run-out period, no slow reduction in the dose of the ICS. And then for 6 months, patients who'd previously received inhaled corticosteroids either got dual bronchodilator or continued on triple therapy. So both of those trials addressing the question of what happens if we take away inhaled steroid in a randomized study. And so this is the contrast between the two. They both sort of address slightly different questions. This one was gradual withdrawal. Some patients were, and some patients were not receiving triple therapy at the onset. So some people were stepped up and then taken off in Wisdom. And it enrolled patients with severe and very severe COPD with a history of at least one exacerbation. Sunset was different because it was a direct step down, no weaning off of the dose. Patients all had to be on triple therapy for 6 months prior to enrollment, and it had a different patient population in terms of less frequent exacerbators and milder lung function. So looking first now at Wisdom, many of you will be aware there was no evidence in Wisdom of an overall increase in exacerbations after ICS withdrawal. So we looked at that and we considered that in making the guideline, but we also looked at the subgroup analyses. And here's the important subgroup analyses. This is patients that had their inhaled steroid taken away who had a history of just one exacerbation in the previous year. So that would be your gold A and B population. And as you can see, none of these rate ratios, which is the increase in exacerbations, cross over the threshold, regardless of the eosinophil count, into an increased risk with taking away ICS. But if I now focus your attention to the right-hand side of this slide, in those that had a history of exacerbations, 2 or more per year, and had a raised blood eosinophil count above 300, you can see these estimates now separating from the middle line. You have a statistically significant increase in exacerbations if you have a history of exacerbations and a raised blood eosinophil count, and we take away your inhaled steroid. So that's an important message from the Wisdom study. If we look at Sunset, similar to Wisdom, in the overall patient population, there was no increased risk with taking away inhaled steroid. So the frequency of exacerbations between those groups are the same. But when we look at the eosinophil subgroups, you get the same message that above 300 cells, there's a statistically significant increase in exacerbations if ICS is taken away. Whereas in those with the lower blood eosinophil counts, there's no suggestion of increased risk. So we took all 4 studies that we found, including those 2 large and informative studies, and we pooled these, and this is the meta-analysis from the paper that we published in the ERJ, which very clearly shows the separation between those that have low blood eosinophil counts, where there's no increased risk of exacerbation, and this outlier to the right here, which is patients that have a raised blood eosinophil count who are experiencing more exacerbations after we withdraw ICS. And that we quantified that as a 63% increased risk of exacerbations with no evidence of heterogeneity, meaning that all of the studies were giving us the same message. So as you'll see in a moment, we therefore made recommendations to use the eosinophil count as part of the decision-making process for withdrawing ICS. But what I want to ask you now is, if you're using eosinophil counts, or if you're thinking about using eosinophil counts, do you feel comfortable using one blood eosinophil count to make your clinical decision about a patient? And I've given you 4 options. One is whether you would like to see a trend over time rather than one, whether you would regard one eosinophil count as potentially ICS responsive, even if it's a few years ago, or yes, I'm comfortable using eosinophil counts, I think they're stable over time, or yes, it's probably not stable, but because it seems to work in clinical trials, I'm happy to use it. So this, I think, will be a really interesting result when it comes through.
And here we are allowed to vote, James.
Oh, very good. Possibly because Ali saw we disagreed about this in the warm-up. I think these are fascinating results. So the majority of people say they'd like to see the trend in eosinophil counts over time before making a decision.
Right.
There's about 30% say because it works in the trials with a single measure, I feel comfortable using a single measure. So Mark, What's your view on this?
Well, I must confess that I vote D. They are not absolutely stable. They may vary, but most of the data we have from clinical trials come from a single determination, and they are very consistent. So I think that with exceptions, we can rely on one measurement. But again, this is not an exact, I mean, this is not mathematics, this is biology, and we know that there's variability.
So, I mean, I agree with that. From a strictly evidence-based medicine perspective, all of the data I showed you for ICS introduction is based on one measurement, and it works. And our data in the meta-analysis is from one measurement, and it works. So it's clear that one measurement does work in these trials. On the other hand, I've been doing this in clinical practice now for some time, and I find it extremely reassuring if I see a patient with an eosinophil count of 150, and I can press a button and see 10 other measurements and they're all in the same range. There's something about that makes me much more confident with my decision. Although I have no evidence to back that particular set of decisions up. So I think that probably reflects the fact that there's almost an even split between those two points of view, probably reflects an important evidence gap for this eosinophil subject.
That's right.
So I'm going to try and make you feel a little bit better about the one-off eosinophil measurement. And this is, again, lovely data from Mona Bafadel. And this is now looking at a population that have had multiple eosinophil counts. So each dot along the bottom is a patient, and they've been divided now into patients that are always below 400 cells. And you can see there's quite a bit of variability, that the patients more or less stay within their lane, whereas patients that sometimes become eosinophilic here show a high degree of variability. So there are some COPD patients that show a lot of variability in their eosinophil counts. And patients that are very high tend to stay very high. So I think this would support Mark's view and the view of the guidelines that although there will be some change, there isn't extreme changes between different time points. Patients tend to stay within a range of blood eosinophil counts. That means one value or a few values is going to give you an accurate reflection of that person. I would make an important point here, which is that oral steroids will rapidly drop the ICS. Oral steroids will rapidly drop the eosinophil count to a very low level and will give you a misleading impression. So remember only to use values when patients have not been on steroids. So based on all of this data, Mark and I and the panel made a recommendation that for patients with COPD without a history of frequent exacerbations, we should consider ICS withdrawal. But we recommended not to withdraw ICS in patients who had blood eosinophil counts above 300. And then we said, if ICS are withdrawn, patients should be treated with one or two long-acting bronchodilators. And I have to say, in my practice, that's 2 bronchodilators. So now that's what we said in the guidelines. One of the points that I think is important to address, because there were 2 trials that did it differently, is do you stop it abruptly or do you wean down the dose? And in your practice, do you step down to dual bronchodilator or single bronchodilator? And this one, I hope we'll get a bit of a consensus because we did make a recommendation on this in the guideline. Okay, so I'm surprised, Mark, that there's 43% that wean down the dose slowly, but
right. Well, at least both options, they would change to dual bronchodilator, which is the most appropriate. But yeah, there's still people who are a bit reluctant to discontinue abruptly.
Yeah. So I would say that because we saw the very reassuring data from the trial that I showed, Sunset and other trials that did this abruptly, that gives me a lot of confidence that doing it abruptly is not going to be a problem. However, there's obviously never been a direct comparison between the two, so it's difficult to say for sure which is the right approach. We recommended in the guideline that it was likely to be as effective to do it abruptly, and clearly it's easier to do everything at a single visit.
Yes.
So this is the summary of the recommendations. So we're coming to the end of the formal presentation, and we're going to do some case studies to finish off in the last 5 to 10 minutes of the formal presentation before we get into the Q&A. So, of course, this guideline doesn't apply to patients with asthma, but it's important to recognize that. We recommend to ask patients about their history of exacerbations and check the blood eosinophil counts. And then based on the eosinophil count and the history, is that those with eosinophil counts above 300 should not have ICS withdrawn, because that's a biology that responds to steroids, and there's an increased risk of exacerbations. But in those that have blood eosinophil counts less than 300, we make a distinction between those that have frequent exacerbations and those that don't. So in those that don't have a history of frequent exacerbations, you can argue they should never have been on inhaled steroid in the first place. And therefore, switching to bronchodilators is very likely to be safe and effective. We didn't make a recommendation in those with a history of frequent exacerbations. And we'll come to discussing that during the case studies, because they're a much more difficult group because there's less evidence. We don't do trials in people with very high risk of exacerbation. So the last few slides are actually case studies where we're going to try and start off easy and then build up to some of the more difficult decisions. The first one is a 70-year-old man with a history of patient with a history of COPD, FEV1 44%, 1 exacerbation, a blood eosinophil count of 320 cells, never been hospitalized, and breathless, and on LAMA monotherapy. What would you do for this patient? And I'm allowed to vote now, Mark. This is good.
Oh, yeah.
So while we're waiting for the results, so most people will have voted by now. There we go.
Here it is. So change to LABA/LAMA is first, and then change to triple second. Well, that's what I would have. I must confess that I voted change to LABA/LAMA, but honestly, I would like to have more information, because I must confess that I would have changed my vote if this exacerbation would have been a severe exacerbation that required hospital admission. Then I would probably have gone for triple. And also, as you mentioned before, I would have liked to see in this particular case if these eosinophils of more than 300 were relatively stable or not. But I think if this exacerbation was just ambulatory exacerbation, not a severe exacerbation, I would have given this patient an opportunity to continue with LABA/LAMA and see what happens. Because really, it's really breathlessness, and I think that this is for the patient probably more important than this single exacerbation. But I accept that some people may have different opinions.
Yeah, and I think this is, I mean, we've deliberately made these difficult because we know we have a well-informed audience here. We're not asking simple questions. This, I think, is a tricky one because they may well respond if they've got the biology, they've got eosinophils. On the other hand, the gold algorithm would say try LABA/LAMA first before escalating to triple. What I wouldn't do here is change to ICS/LABA. So I just make that point that although they have the blood eosinophils, they have quite significant breathlessness, and they're going to need the dual bronchodilator regardless of whether you add in the ICS as well. So I think that's an important point to make, that breathlessness is probably the dominant problem here, maybe driving some of the exacerbations. So I think LABA/LAMA or triple is the answer here. So let's move on. A 66-year-old man, COPD, FEV1 64% predicted, but now 2 exacerbations, but has a blood eosinophil count of 120 cells, never been hospitalized and on LABA/LAMA combination therapy already. So again, challenging you with this one. So most people have probably voted. So what would you do here, Mark?
Oh, here it is. So you can see that, well, most people went for triple therapy. So I wouldn't have gone for triple therapy first in this patient. So I honestly, I would have tried something that is not here, which is rehabilitation. And also in the case that these exacerbations are infective and they have had purulent sputum and they responded to antibiotics, I would have tried azithromycin first. 120 cells, 120 eosinophils are quite low, and I don't expect much results from ICS. But so again, this is not crystal clear.
This case is deliberately chosen because the gold cutoff, of course, is 100. So if you're following the gold algorithm, the 40% are correct, but it's right on the border of that gold algorithm. And many people use 150 as their cutoff for defining ICS response. So it's quite unlikely this patient's going to have a great response to ICS. As you say, Mark, I find asking patients to describe their exacerbations extremely helpful. If they describe purulent exacerbations that always get better with antibiotics, I find that to be very unlikely to respond to steroid. Whereas if they describe wheezy exacerbations where they always need oral steroid, that does seem to be discriminating even in the effect, even in the absence of an eosinophil count. So 82-year-old lady now with multiple comorbidities, including osteoporosis, an FEV1 of 58% predicted, no exacerbations, an eosinophil count of 170, doesn't remember why she was started on her inhalers, still smoking, and on ICS LABA and LAMA as individual inhalers. So would you withdraw? There we go.
Oh, yeah. Well, this is apparently easier, so there is more consensus here. And actually, according to the ERS guideline that you presented, this is a clear candidate for withdrawal of inhaled steroids. In fact, she's an old lady with a risk of side effects and therefore no exacerbations, low eosinophil count. So this lady should not be on ICS.
Yeah. If you're ever going to do it, this is the patient you're going to do it in, because they've got every they've got every indication for not being on an ICS, including, there is some evidence that smoking reduces the efficacy of ICS as well, which isn't something we mention in the guideline, but there is certainly some evidence out there. So the final case, I think, a 71-year-old lady, COPD, mild bronchiectasis on CT. I always have to work bronchiectasis into it somehow, Mark. She's got FEV1 of 88% predicted, no exacerbations in the past year, 2 to 3 exacerbations prior to starting the inhalers 10 years ago, though. Blood eosinophil count of 230, and she's very symptomatic with lots of cough, sputum, and shortness of breath, currently on triple. Would you take away the ICS?
Okay, so, well, there are a lot of people wanting to add azithromycin, which could make a lot of sense if with bronchiectasis and frequent exacerbations probably of bacterial origin, but it does not respond to the question if ICS could be withdrawn, because we can do both. You can withdraw ICS and introduce azithromycin or continue with ICS. Well, in this case, I would say that I would probably try to discontinue ICS because he has a very well preserved FEV1, and also probably he has infective exacerbations, and blood eosinophils is between 200 and below 300. Although, as you mentioned in the guideline, there is a gray area here in patients who had frequent exacerbations, and we did not establish any clear recommendation. But I think that this lady would deserve to try to reduce ICS, because with ICS, there is a risk to increase bacterial loads in patients who are colonized and perhaps may favor recurrent bacterial exacerbations.
So let me ask you the question that this is hinting at, because it's a question we get all the time with ICS withdrawal. Is we're wanting to withdraw in patients that have a low frequency of exacerbations, but people will say, but the reason the patient is not having exacerbations is because they're on ICS. So like this lady who says, hey, I've not had any exacerbations for years, but many years ago I did, and maybe it's the inhalers that have stopped me from having exacerbations. How do you respond to that, Mark?
Well, my approach is, again, looking at the eosinophils. So we have plenty of evidence that patients who have high blood eosinophil counts, these patients have a clear, significant clinical effect of ICS. In contrast, patients with low eosinophils, they probably have no effect. So therefore, if I see a patient on ICS without exacerbations and low eosinophils, I think that this patient is not having exacerbations despite ICS, but not because of ICS. And the other way around, if the patient has high eosinophils. In this case, the levels are, well, in this gray area again, so you need to take into consideration other aspects.
So I completely agree with that. And so a history from 10 years ago, I think, is so prone to all sorts of biases. And there's lots of reasons why the patient's exacerbation frequency might have changed over time, including potentially giving up smoking or doing pulmonary rehabilitation. So I completely agree.
Yeah. So
we've come to the end of the presentation, and that means, I'm wrong. We've got one more MCQ. I'm sorry. So 77-year-old lady with COPD, FEV1 of 51% predicted, no bronchodilator reversibility, no exacerbations in the past year, blood eosinophil count of 80, but she tells you she was diagnosed with asthma for around 10 years before she was diagnosed with COPD. So I warned we were going to make this difficult for you.
Okay. So I see that most people believe on the previous diagnosis of asthma, despite all the other signs. So, well, it is understandable and it's reasonable, although with these very low levels of eosinophils, if the patient has really a COPD, she was a smoker, a significant smoker with symptoms of COPD, I would have tried to discontinue ICS as well, because she fits in the criteria of not responding to ICS. Although again, our guideline or ERS guideline does not apply to patients with the diagnosis of asthma. We should investigate if this diagnosis of asthma were real and was well funded.
Yeah. And there's a whole other webinar to be done on the quality of asthma diagnosis. But certainly, I think in this case, if I thought the asthma diagnosis was well-founded, there's other patients where it would be better to withdraw ICS than this case, I suspect.
That's right. Thank you, James. I don't know, you want to summarize, or we can summarize later for the audience. But now we have a lot of questions in the chat, so we will try to address most of them during the remaining 10 minutes. And let me ask you. For example, here, there is one question that says, do you recommend to stop ICS at the same time when a COPD patient develops pneumonia?
So I wouldn't necessarily do that. I think it's difficult then to evaluate the patient in terms of their symptoms. They may be receiving inhaled oral corticosteroid at the time they're being treated for a pneumonia/exacerbation. And so you may not be able to evaluate their eosinophil counts. So I think it's better to deal with ICS withdrawal when the patient's stable. So if you've seen a patient with pneumonia and you're thinking about ICS withdrawal, see them a couple of months later once they've recovered and discuss their inhaled therapy at that point.
Right. I have another question from Professor Sayiner from Izmir in Turkey. said, do we have any clinical evidence that pneumococcal infections increase in severe COPD? For example, in relation to the findings of dysbiosis in ICS users?
So the answer to your first question is yes. So in almost any study that's done on risk factors for pneumococcal disease, COPD and chronic respiratory disease comes out as one of the top risk factors. That's why we recommend pneumococcal vaccination for all of our COPD patients. But in terms of the dysbiosis data that I showed you, we don't know for sure that ICS increases loads of Streptococcus pneumoniae, because that was a microbiome study which shows increases in Streptococcus species. That includes a lot of different species. So there's more studies needing to be done to see whether that's really pneumococcal. And actually, a lot of the pneumonia we see in COPD is caused by gram-negative organisms like Haemophilus. And there's lots of great data on that. So it may not be all just a Streptococcus problem.
And another great and difficult question. With the evidence of reduced mortality with triple therapy in COPD and frequent exacerbations, which would be the criteria to discontinue ICS? Would it modify the criteria to discontinue ICS?
So I think that's a really great question, and it's really in two parts. It's what do we think about the mortality data, and then how does that impact on the decision to withdraw ICS? So we have a couple of large trials now that show a reduction in mortality in patients taking triple therapy compared to bronchodilators over a period of 1 year. Now, if I was designing a study for long-term mortality in COPD, I wouldn't design a 1-year study, because these patients take these inhalers for, in many cases, decades. And when we've seen long-term mortality studies like TORCH, like other long-term mortality studies, they haven't shown a benefit of ICS on mortality. So I think there's a hint there that there is an association with reduced mortality, but there is a need for more studies and longer-term studies, because these weren't studies designed to address that question. So I don't think that should guide all of our decision-making.
I agree.
But the other part of this is that for ICS withdrawal, we're talking about patients without a history of frequent exacerbations, which are not the patients that are being included in those trials. So I think we should separate those issues of initiating ICS in frequent exacerbators and withdrawing it in patients that don't have frequent exacerbations.
I agree. And I would like to add something also in relation with another question that we had. And there was a question asking whether there is also a relation between blood eosinophil counts and the efficacy of triple therapy in terms of reducing mortality. And in fact, there is. I mean, in the last paper published on mortality in the triple therapy studies, there was a significant reduction in mortality in patients with high eosinophil counts, but not in patients with low eosinophil counts. And therefore, these support, again, our recommendation of withdrawal also based on blood eosinophil counts.
Yeah. And I think that's incredibly exciting. Isn't it great that we have this biomarker and we have so much data for this biomarker that we can confidently use it in our practice? I think that's something to really step back and go, wow, this is really useful, because all of the data is so consistent with the use of this biomarker.
That's true. I have another question here. Is there a difference between ICS in terms of pneumonia risk? Which one do you prefer for patients who really need ICS?
So that's a really difficult question. So there's never any comparative studies. So although some trials show higher rates of mortality, and particularly some of the fluticasone studies have shown higher rates in their trials than some of the others, that may reflect differences in the patient population being recruited and how carefully pneumonia was looked for, rather than really the biology of the drugs. So I think the jury is out on that. What I would say is that I think the side effects of ICS in COPD are dose dependent. I think the benefit is not clearly dose dependent. And so I like to use the lowest dose and lowest potency steroid I can get away with.
Yeah. We have another very interesting question. How are we going to control inflammation without ICS in COPD?
Great question. So I think what we're pointing at towards with this eosinophil data is not all inflammation is equal. So if you've got neutrophilic inflammation, ICS is not going to do a thing for that. In fact, there's data that ICS prolong the lifespan of neutrophils may even exacerbate that type of inflammation. So I think the first answer to your question is, what type of inflammation does your patient have? If they have eosinophilic inflammation, ICS is what will control that. If they've got neutrophilic inflammation, it's bronchodilators. And as we showed with the bronchiectasis case, which is classic neutrophil dominant disease, azithromycin is a much more potent anti-inflammatory from a neutrophil perspective than an inhaled steroid. And I use it regularly in my very severe patients with COPD that have frequent exacerbations and neutrophilic disease. So I think it's use the right anti-inflammatory for the right kind of inflammation.
That's right. So one size does not fit all. So there are different types of inflammation in COPD. So let me see. How can we educate elderly patients on steroids to withdraw the same as they tend to become dependent, at least psychologically? If I understand it correctly, it means how can we really convince patients who feel dependent on the drugs for their well-being to discontinue one drug when they are okay? They say, well, as you said, I'm okay because I'm taking this drug. Why should I discontinue? Yeah,
so that's a really great question. So that's a real challenge, because we're taking something away, and as doctors, we're used to adding something in. We're used to saying to patients, "This is going to make you feel better," and there's a benefit to patients of doing that. Here, we're saying we're taking something away. So we have to explain that very clearly to patients. You have to explain why you're doing it, what the likely benefits of withdrawing the ICS is, and what you're going to do if the patient has any problems. So you can say to them, look, I'm going to take this away because your blood count is this, you're not having exacerbations. I think it's potentially doing more harm than good for you. But look, if you were to have a number of exacerbations over the next year, we could add the inhaled steroid back in. So I'm going to follow you up over the next year to make sure that everything's okay. And that's what I do routinely with my patients. My experience with it is that very few patients, if you pick the right one, will actually have exacerbations. But having that conversation at the beginning about why you're doing it and making sure that they're on board with that is really important. Because if they say, no, I really love this inhaler and I want to stay on it, you're not going to win that. You're not going to win that argument, because they're going to feel worse when you take it away.
You're right. We have only a couple of minutes and we have still some questions. I want to make at least a couple of them, so it should be short answers. Can we safely disregard any effect on FEV1 decline, I guess, when discontinuing ICS?
So I think the answer to that is yes and no. So, for example, Wisdom showed an effect on FEV1, but it was modest. It was less than the 100 mils we regard as clinically meaningful, and most of the other trials showed similar magnitudes of FEV1. We looked at that formally in the guideline, and we didn't see a clinically meaningful decline in FEV1. So I think the answer to your question is yes, you may see a small change in FEV1, but it's not going to be enough that the patient will notice it or that it will matter. I mean, is that something that you look at, Mark, FEV1? Not really. And also we saw in some studies that is, again, dependent on blood eosinophil counts. See, the patients in the sub-analysis of Wisdom, the patients who really lost significant amount of FEV1 were those with high blood eosinophils when they were discontinued. So by making the right decision, probably the impact on FEV1 is minimal, if any. And one short question and short answer. By checking historic eosinophil counts, how far back in time is relevant? Oh, so I think it's probably not helpful to look back more than a few years, because obviously patients' disease changes over time, and it's harder to then check when the patient was on steroids, for example. So I tend to look back over the last 2 to 3 years. But you also see some patients where it's very consistent over a 10-year period. So I think use the data you have available, but the more recent data is more helpful. What do you think, Mark? No, I do agree. I mean, I also have the opportunity to see historical records, but I never go back more than a couple of years. Unfortunately, most of the patients are chronically ill, have comorbidities, and they have several blood analyses over the course of 1 year or a couple of years. So we have enough data points to make a decision. That's what I find as well. Yeah. Well, with this, in my watch is 7 o'clock sharp. So it has been a real pleasure to share this session with James and with all of you.
I want to thank the ERS for organizing these interesting webinars, and I invite you to attend the rest of the series. Thank you for your attention today, for your participation, for being so active, for posting such interesting questions. And I hope we could respond most of them in the clearest way possible. Thank you for your attention, and I hope to see you in person in the near future.